Everybody. Just so the folks, just go around the room real quick, folks online know who is here in the room. I'm Mark Garvin.
Over this way, Jody Merritt,
John Cummings.
Matt Jarvis.
Mark
Justin Fitz, Sam Hiddle,
Jerry Mott.
Jeremy Gordon.
Nolan Widows.
Again.
Jennifer Lee.
Lyle Morris.
Oh,
And then looks like we have Allison Kelly. I have,
Hi, everybody.
just because I can recognize, and then Kevin Upkeys, Chief Haynes, and then Lieutenant Hall too. So, hey, awesome. All right, next thing up on the agenda is the CARES update.
that's gonna start us off.
Okay.
Do I need to stand or? Just sit? Oh, this one. Wow. All right, so I'm assuming everybody knows that our CARES building has been built and it is open. Not every day, but I'll get into that in a second. So if click. Okay, so yeah, 24/7, 365. We have our own hotline, our 503-623-9289, press 1, Monday through Friday, 8 to 5. That's the same hours as you see as our walk-in services at Care Center. Anybody can walk in there. It doesn't matter about insurance or anything. We still serve every single person that comes in there. And it also coincides with when our we have the 623-9289 press 1. That's our own like inside crisis line. But we get our phone calls. We have in person, of course. This is a little I go a different direction. Oh, you want to talk about telehealth? Okay, yeah. I do have cards that I brought that Jennifer had produced a while back, and for law enforcement, EMTs, West Valley Hospital, 90-day and 911, they can all call us directly 24/7/365 at 503-623-7555. I will give out cards with a what's that barcode? QR code, thank you. I'm not technical. A QR code that can have some more information on that. But yeah, you can call that phone number 24/7. And I even go as far as saying, I've noticed deputies and officers like in knock shift, like in graveyard, are a little hesitant to call us if they have a question. Other than, okay, if we're definitely want a mobile response, then we'll call. And I'm like, we get paid to be on for whoever gets paid to answer that phone. So if you have a consultation, if you have a question, it's no different than all the years that we all grown up through the ranks have done. Just call. You're just not going to just call me because I'm tired. So call that number if you have a consultation, anything. So our in-person response, our staffing, because that's going to cover the telehealth fee. So our in-person response again is 24/7, teams of 2 when staffing is available. And that was traditionally how you guys, law enforcement, everybody had seen it up to this point. Has typically been a QMHP, a qualified mental health professional. That's a master's level clinician, crisis clinician, and then a QMHA, a case manager, which is typically a lived experience and or bachelor level individual. And there's a couple of things that there's actually one thing really now that the QMHP can do, the QMHA cannot, and that is a risk assessment. And so we have, what's that?
And a DC.
And a director's custody. Yeah, sorry. So the walk-ins, that's pretty self-explanatory. Also with walk-ins, we still have you all still have the ability to bring someone to us. So if you had someone out, and however your officers or deputies do it within their policies and procedures, they can voluntarily voluntarily bring them to our building. We do have a designated spot right in the front for law enforcement cars. For vehicles, so that's still a thing. So here's where it gets a little bit, you're gonna see it a little bit different. Due to staffing, and this is pretty statewide, it's been very, very difficult to hire QMHPs. Only QMHPs, I guess it's not cool enough anymore. It used to be really cool to be a crisis worker. Now apparently it's not because nobody wants to do it. And I will tell you that that is pretty across the board, even pre-COVID. Pre-COVID, we've struggled to get QMHPs to apply. So Marion's the same way, Yamhill a little bit. I do not know about Benton County. And even Lane County is struggling at this point. So something that we've had to do here, and it actually goes pretty much into effect this week at some time, is we will be sending out 2 QMHAs. So they do not have the ability to write directors. They do not have the ability to do a risk assessment. So we're going to try what some other counties and places in the nation are doing. And that is the 2 QMHAs, you call them out to the scene, they'll go out, and I'm telling you, the QMHAs on our team are top notch. I would actually say there's a couple of them that could probably run circles over some QMHPs on our team. So that team of 2 will go out. I don't see officers and deputies or anybody on scene really seeing a difference other than new faces. They're gonna do all that. If they need a risk assessment, this is where, and even I'm gonna be like, okay, let's see how this goes. We will have a QMHP of the day stationed at the academy building, and one of the 2 QMHAs, one of the people on scene will do the telehealth video thing about that Chromebook or whatever, and the person that's a QMHP of the day, they'll get online, they'll interview the client, person of interest, 10-15 minutes. Some of them will probably take 30 minutes, but because it's going to be kind of new to them. And so then that person will disconnect and the 2 QMHAs will do everything else. DCs, that's going to be a little trickier. That's going to add a little bit more time because from my understanding, well, I do know that the QMHAs cannot do directors. And so they'll never be on the BOC's list or anything like that. How we get QMHP of the day to fill it out and get it out there, that will be interesting. Now, with that said, we probably only do about 6, 7, or 8 a year, and we're only talking day shift, only talking from 07:30 to 18:30, yeah, 18:30. So 07:30 to 6:30 at night. Because our night shift is not changing at all. We still have 2 QMHPs each day of the week, and they can call a QMHA in. So you will, if any of your people are working night shift, you won't see any difference. There won't be any videos or anything like that. It's just the day shift. I think I've explained that to the best of my abilities. Assuming there'll be questions later, so click. Yeah, this is yours, right? I think, but I'll just. I'm assuming that you can all read, so you can see that that's all you. That's everybody that we respond to as far as, I mean, there's a lot more, but for this room, that's that. So, okay. Those are all our other people. West Valley Hospital, we still go to for now, child welfare. FCO, we're in Monmouth/Independence because I don't know exactly. I always thought it was the SCARs, so that was Independence, but sorry, I don't know the boundary. Veteran Services, which really is FCO inside FCO. So we didn't know we don't have Eric Andrew or Nikki. So his name is Joe Bell, decent dude. School-based mental health, those are that's also FCO. Those are school-based mental health people inside the schools. And then we, of course. Click, please.
No, wait, no,
No
go
click.
back. So that's what Doug, did you get it done in 12?
Well, I think I have.
Well, too bad. It's for questions. So one of the things that I've been trying to do, and then also Doug is assisting me with, is to speak with all of our community partners and try to develop workflows based on some of our challenges and some of their new rules and challenges. And so it's been really interesting. I've spoken with a few of you about that, about just what Doug was talking about. What if we don't have a QMHP and we need to do a directors? Can law enforcement help us out? And everybody said yes. So that was exciting. And then Chief Mott and Chief Pinellas have given me workflows that kind of say when they can respond and how they will respond, so that our team knows when they can call and how they should call. And that's been really helpful too. We're doing the same thing with the school-based mental health. There's a big workflow being developed, and it has to do with the schools, the counselors, the school-based mental health therapist, the resource officer, mental health. Remember, that might be it. But going through each step by step, what is our role? Where do we step in? Where does the resource officer step in? What happens? I think there's a lot of times when, especially if the school-based therapists aren't there, that sometimes the school will call and we wouldn't have been the first step. It would have been a school-based therapist or this, what is it, CRO, I think? SRO? SRO, thank you. Yes, hold on. SRO who would have stepped in. So working together, I think we can fill in gaps of kids that we've missed and also provide more comprehensive services and understand each other's services better. And that particular group with the school-based therapists, myself, Doug, we will be meeting regularly to just continue to maintain that communication. The same with DHS. We're having meetings with DHS. What does our crisis team do when you're removing a child? What does that role look like for us? Because I know that our staff have struggled with that at times when there's law enforcement, DHS, and others there. So when do they step in versus when are other people stepping in? So just clarifying some of those difficult situations that arise where people aren't happy with each other because they might have not done their job. But to try to clarify, I think that will really help. We're doing the same thing with law enforcement, just by, I think Doug will be attending their staff meetings regularly.
Yeah, I talked with Lieutenant. Tell me. Lieutenant McCarthy, he said I could come. I never remember McCarthy. I'm gonna talk to him, I'll talk to the sheriff and Lieutenant Newman about. Some of you guys remember that we used to come to, like Sarah and I used to come to briefings and stuff every once in a while. So I'd like to get back to that. So, you know, not necessarily doesn't have to be regular, but every once in a while. So you guys have access to us and me to consult with and figure out, you know, rather than one meeting every 5 or 6 months. I want to make sure that because our services are changing a little bit. And I want to make sure that we're providing the correct service, the right service. Support.
This is an interesting theme, which I will get to, but I would like to give you a little background. This is SAMHSA, it's a really long name. Crisis Response Training Technical Assistance Center, partnering with emergency and first responder across the continuum of care learning collaborative. So what happened is Miriam, Polk, 988 and 911 were accepted as a team, which there's only 10 teams in the nation that were accepted. And so we're really excited about this project. And basically it is about how we can better collaborate and support each other. And so we meet 4 times. I think I have it on the next sheet, but that's okay. So the people in it are Ann Osela, she's from PCC/BHCC now. Northwest Human Services is Mel Lawson, myself from Polk County, and Chief Lavelle from WBCC. So we meet once a month with SAMHSA and the other 9 teams from the state, from the country. And then we meet individually. and review parts of our project. And the project is on the next page. This gives you a bit of an overview about it. Basically, it just they explain law enforcement, 911 has always been the first point of access for anything. And so then law enforcement, fire, EMSS have always been the people who respond, including the behavioral health crisis. And I remember when I first started working in crisis, I would see all of our police reports come in and say, wow, this is all behavioral health, behavioral health, behavioral health, which was interesting to me. But now we're starting to change things are shifting. So with regard to this partnership, we had a kickoff already. We're clarifying roles, applying the strategies to collaborative communication, identifying strategies to collect and analyze data and measure outcomes. And then we present our project at the last session. So each team will present their project, what their collaboration in their system and area looks like. So I had computer problems and ended up having to get their SharePoint on my computer at home. But as I was speaking with the person who was helping me, I was explaining what we had done. And she's like, wow, you guys are way ahead of the game. And so what I'm speaking to about what we have done, Sheriff knows a little bit about this. We have been working with WBCC, Marion, Polk, Lincoln, and Salem, and the sheriff, Salem PD. And so we've been meeting to try to figure out how 911 can transfer EDP calls to 988. And it's been great. And they have already started to do that, but there's still kind of more planning and more gaps. And so I have a few notes. So basically, WBCC is the triage point. All EDP calls will be transferred to 988, and 988 is the crisis response entry pathway. County crisis providers are the connection to care. So there will be a warm handoff from 911 to 988 for crisis counseling and safety planning. And then they're currently working, this is a work in progress, on how the specific transfer process to transfer back to 911. The 911 to 988 handoff for crisis counseling, safety planning with linkage to services, and the 988 to 911 return to dispatch when risk escalates or if there's medical needs present, followed by a field response and coordinated connection to county crisis. So if the call goes from 911 to 988, flips back to 911, then 911 responds along with mobile crisis responding as well. The field response is county crisis, basically. So CRT, BHCC, which is the LPSCC, cares and county crisis teams for stabilization, risk evaluation, safety planning, referrals, and ongoing linkage. And this model was selected because it addressed the gaps for the behavioral health and the chronic need calls that come from that come into 911. You guys have had them before, and I think some of you have contacted us to try to help minimize those 90 calls a day. So that's one of the reasons why they're trying to get the people to the right place for the services that can support them, whether it's resources, somebody to talk to, mobile crisis response, or first responders. So basically, I think the hope is that it's going to reduce the burden on WBCC as well as law enforcement just by getting us out into the community to help people or out to the crisis hotline rather than them being the crisis hotline. And so what was really interesting, this meeting started last year and they started going live with some of it in January. And this particular project that we got accepted to is basically what we're doing. So that's why we're way ahead of the game. So it's really exciting. I think probably the focus this year is just collaborative partnerships, working together, figuring out how do we best work with our partners in crisis response and mobile crisis. What does that look like? What do we need to change? I know they've had laws and rules that have changed that have made things a little bit difficult with law enforcement. So what does that look like? What does EMT response with corresponding with crisis look like? And I think that's about it. So that's just the focus that we have. Doug and I will be doing that, working with all the different community partners to see just how we can improve services, how we can help, what we can do, and kind of basically outline that on paper in a visual. I think that piece is really helpful because we don't remember words all the time. So if we have something that's like, oh yeah, this is it, all of this, and that's what we're trying to do for our staff to help them better, just better prepare, better see how the process looks, what to do in extreme circumstances when somebody might not be available to provide them with support. What does that look like? So that's our this year project, I guess. And Doug, I think I left you a little, but Doug is what's called field commander and community, what is it? Oh, sorry. Community response. Manager.
Yeah, I bet you guys do. So, yes, so my role's changed a tad bit. And it will be confusing for a while based on our staffing, because pretty much right now, well, I am the QMHP for Saturday. If I have my way, I will pull rank and not do it by video. Because that's just, I don't know if that will work. But however, that's where. No. So I have been changed to what is called community response manager, and that has more to do with the other hats that I wear, post-vention, veteran stuff, and hopefully we never have one, but local disaster, that kind of stuff. So I have my hand in those cookie jars, but those are far between. Other than post-vention, I would say that when somebody in our account, if any of you officers or EMTs or paramedics, POs, whatever, ever have anybody that dies by suicide, please have them reach out to me as soon as possible. And I'll prefer it, around that 05:30, so I can wake up. But the sooner you can let me know, the sooner I can do what I need to do to let all agencies and schools and all my contacts know, because I would assume that most of us have been in a position where you do not want to get, you don't want to go to work or school or anything on a Monday morning, knowing that somebody in your agency or the school has passed away by suicide. You don't want to be prepared for that. So that's still part of my job. I didn't give that up yet.
And we've expanded from just 24 and under to work with individuals of all ages and their families.
Yeah, that's right, sorry. I'm so used to doing it for everybody that I always forget there's actually Senate Bill 561, so my bad. However, so that's that part. But the field commander part, not my phrasing. Yeah, that's a little too much for me, but that's, if Noelle's listening, that apparently was her title for me. So those things we gotta do is, yeah, we're getting, like we told you, there's staffing issues. We're getting newer people to do crisis work. And it is not clinic therapy. It is not, come to my office and look at my Himalayan salt lamp and my fake waterfalls and all that. It's not any of that. So it is a little tricky. So we decided that we probably need to have our newer staff and some of our older staff retrained, but every few months I'll be going out on call with each and every worker, and I will be like, they'll be primary and I'll be like backup, and I'll make sure that everything's going correctly, but I'll also be making sure that they have the core competencies to continue doing crisis work, because it has changed more than, I've never seen as much change in the last year than I have in the amount of time I've been doing this. So we want to make sure our people are out there doing it correctly, doing it safely, and interacting with our community partners professionally and adequately. There will be times where you all or your staff will see me out there. But because on Saturdays I'm in, so I respond. So I'll be crisis responder versus crisis community response manager. So yeah. So I'm actually pretty excited about that. Questions?
How do the police officer holds intersect with what you guys are doing? Second part to that, police officer holds, you guys still having to go to Salem, or is West Valley Hospital picking up something?
So. Correct, yeah, West Valley's in the whole facility, so that hasn't changed.
Yeah.
Back in the day, so yeah. Our rules for a DC are the same as a POC. Nearest whole facility, so as we all know, 98% of it's gonna be shed, and then if you're out here far enough, you go good same.
And if there does need to be help with that crisis response, they can always call our 7555 number and have somebody respond to the scene to help support them.
Yeah, I know during the day, since we're talking day shift, really these changes, like I said, night shift pretty much stays the same. I mean, I'm not sure about Mondays and Tuesdays, but I can see if the DC has to be rolled or done. I know that the QHP, for whatever reasons, can't do it. I mean, you know, somebody's gotta get out there, so it will probably be me. It's not supposed to be me, but I know by practice that's probably the plan. That's fine.
Doug, you said there's some change. What's the biggest changes? That's you're here to.
Team of two. I don't think. Maybe that's it. This is kind of more maybe a question for the sheriff and the chiefs that have been in this community and doing their jobs. Probably, yeah, longer than me even. But we've always, I mean, from the Dustins to me, even go way back to Scott Anderson, as quirky as he may have been, got the job done. We've always gone out. Never law enforcement have asked us. So that won't be too much of a change for some of us. But teams of two, the whole QMHA going out by themselves, or team of two without a P, that really, it's gonna be, for me, I'm gonna see the change because it's night and day just based on experience. Because currently right now, the only QMHPs on our team are Kevin, Andre, and myself, Jennifer. And so, we're gonna have brand new people that have been used to, I guess if I was to speak pop talk, going out with a sergeant or a lieutenant or a chief or a sheriff, you know, more experience, you kind of have that safety net there. I don't really see we have more calls, we do, because now everyone in the community has more access for us to go out, so we do work more. That's nice. DCs are all the same, that doesn't change. West Valley is the same. In my opinion, the schools are the same. Would I say that the clientele we see might be a little bit more severely persistent mentally ill? I see different ones though. Like, and I've never had the claim, oh, I see it every day, that's a Tuesday. Now it's a Tuesday, Wednesday, and Thursday. So I do feel that people might be a little more ill. And that makes a struggle because we all run into the same issues that we had for so many years. You take one, I mean, they go to shed, and this isn't a knock on shed. They go to shed and they get kicked in a couple hours, and your deputies and officers are right there again doing the same thing, and that's frustrating. We will tell you that you all have done a wonderful, wonderful job on hiring. The officers and the deputies that are new. I mean, I don't see one for, you know, how late. It looks like he's 9. And I know it's not me getting older, but I've talked with Officer Anderson a few times. Just top notch. And I'm like, I'm really impressed with the interactions and really just the knowledge that that these officers and deputies have. That's really reassuring. So,
Talking to some of the commissioners, they've resurrected the global response crisis teams. They just call it something different so they can choose this funding for burn funding to help fund it.
And it sounds like we're kind of doing that same thing. So
kind of, yeah, I mean, I make my opinion quite, I wish we still had embedded. Wish we still had the Jacob Elise team. And I wish that it's not to me, it's not an either or. I wish we could have both.
Like Marion.
Yes, I really wish we could have one or two embedded teams. Funding's not there right now. And that's what I say. But it's the policy decisions. Yeah, and that's, you roll with it.
Now, how many KMHP openings do you have right now? Bill?
Because we opened it up. Give or take. I don't do the staffing part anymore. I'm kind of glad about that because I think I was really close-minded on hiring. I want people that they kind of do their job and go home to their people. And I thought of fit on the team second, and that's kind of bit me a little bit lately. So I'm now removed, and HR and other people at the academy building, they do the recruiting. They're kind to let me look at the applications, and that's cool. But I will tell you, we hired Audrey, I want to say 3 years ago, almost to the day. And that recruitment, I accidentally forgot to close. And when he was like, dude, you gotta close that. And so I went to close it and Audrey's name was there. So I was like, hey, can we get her via this one? So that worked out. But at that time, the reason I bring that up is we've had 5 recruitments for QMHP since then.
Yeah.
And all 5, and that was pre-COVID, by the way. No, she came after COVID. Yeah. Well, yeah, if I say 3 years. But we've had 5 recruitments and there's only one of those 5 recruitments that had 3 applications. The other ones had 2 or 1. And I will tell you that nobody new has been hired since Ian, but Ian, he left. And so in 3 years, we were able to hire 1 new one because they just were not a good enough fit for us. So yeah, it's kind of I actually think that in the next year or 2, I actually think that the state's gonna have to do something because if this trend continues, I actually think they're gonna start grandmothering, fathering, whatever you call it, QMHAs to be able to do risk assessments.
I think it's kind of like PCPs or physicians. You don't really get to see the doctor anymore. You have an NP or a tech just because they don't have enough to spread around. It's very similar to that.
Allison, do you have a question?
Yeah, thank you. Great presentation and, just really amazing. It's so great. So just a couple things came to mind. I'm kind of wondering if you'd be able to come make a presentation to our mental health team. I don't know if you guys work with Kristen Farrell at all, but we've got some therapists over there. It'd be really good for them to get more educated about all these resources that you've put in place, and just follow up afterwards. And the second thing something that you said, made me want to mention this, that, like if there's a response out to the scene of a violent crime and there are kids involved, kids who are either witnesses or whatever, they've lost a family member or something like that. The protocols regarding referrals to our therapy program, Hope and Wellness, do not require, it's an open panel. You don't have to have an abuse diagnosis to qualify for therapy there. It's just trauma. So those therapists will see kids if they've been exposed to trauma, DV, homicide or whatever, stuff like that. So if they've had that in the family. So I just kind of wanted to mention that. And then it also dawned on me that it's possible, depending on what your responses look like, that, you know, a kid or even actually an adult might be already involved in our therapy program. So I think anything we can do to support your efforts and kind of open those lines of communication is sort of what I'm driving at.
To that would be cool. I believe you're with Liberty House. Okay, so the first part, Kristen Farrell, I know who that is. And if you want Jennifer to go do a presentation, that's cool. No, if you want us to do that, that's totally cool. That's part of the
Community response.
community response stuff. This is PR thing. However, so that's that part. One of the other things, so to have your team aware of is and thank you for the information on Liberty House not just being DV, right? Or just it's trauma altogether.
Child abuse. We serve child abuse victims.
Right, but you also said something about just trauma we could refer to you.
In the therapy program, that's right. That it doesn't, you don't have to have an abuse diagnosis. And also the therapy department serves birth through whatever age. We serve adult survivors of childhood trauma as well.
Yeah, that's outstanding to know. That is one of the things, you know, we do get people with private property. We get to people with private property and private insurance. And so we're trying to build our list of people that are on Providence, people that are on this panel. So knowing that we have more resources really helps our job. And then what was the third thing? Oh, also know, and let your team know, please, that one of the things that the state is now requiring, so just know that it's not just one and done. Like somebody comes in for crisis, we do a risk, or we go out to the scene, we do a risk assessment and see you later, bye. What it does is it opens up a 72-hour period now. They had to pick a sometime, right? The state's not saying that every crisis is done in 72 hours and we're never gonna see the person and we save the day. We know that, but you have to have a period, stop. So we have 72 hours to basically do whatever we can to the most part to stabilize that crisis. And ultimately the goal would be to reduce or eliminate any other crises. But one of the other things that we're now required to do is provider coordination. So if we find out they have a PCP or a counselor or something like that, we call. So if we found out that somebody was seeing like Ms. Farrell or whatever, we would just get that phone number and call and leave a message or whatever. Like I did one for Woo this weekend and all that kind of stuff. So that's kind of helpful, I think. It's different. So cool. Thank you.
Any other questions? All right, appreciate it, thanks. All right, next thing on the agenda is approval of minutes from our last meeting. Also no approval. Is there a say? I can say. Any other questions? All those in favor signify by saying aye. Aye. Any opposed? Perfect. Jody.
So justice and investments, seems like that's all I seem to be talking to you guys about lately. Just to recap, there was an email I asked Sam to send out to all of you about the 23-25 biennium closeout information. So I wanted to see if there were any questions about that. That is something that, as that email identified previously, they've asked us to have a vote to adopt the progress report. They've given different guidance on that, basically stating that the only time we need to do a vote is if we're changing the program, because we've already adopted the program, adopted the budget. So if there's any changes to those types of things, then we would need to do a vote. Otherwise, it's just providing information for you guys to review and ask questions. And so the easiest thing for us to do is email it out and then circle back, or field any type of questions via email, etc. But I wanted to be sure that we had time to hear in case there was any questions that you had thought of after the fact. I know it's a lot of information, so The biggest piece for the closeout was, it closed in December, not in the end of June or July. And that was primarily the CJC had given us additional time. Because that particular biennium, it took them a good 6 months or so even to get us the application and get meet to fund us. So they gave us additional time to utilize those funds. So that was one of the unusual pieces for that biennium piece, and that won't happen again. But for that piece, I know that they close out in December, it was a little different than technically the biennium closed. June 30th, so. So I'll throw that out there before I go on to the next piece.
I just had one question. I noticed in the spreadsheet, this may have been handled before that I wasn't part of, but there weren't any admin costs
No,
listed.
there's not.
I know that grant allows like 10% for admin costs. Was that a decision made? Were there advantages to doing that, or?
Well, unfortunately, we don't get a lot of money, and so we're prioritizing the staffing, because our program hasn't changed in a number of bienniums, so we pay for a half-a-time case manager in the community through behavioral health, and then we also pay for a full-time QHP in the jail, and they work together. And then additionally, there's prescriber hours for individuals in the jail, so if somebody's in need of medication, so we pay for those hours. There's not enough money that we're provided in order for us to carve out the admin costs, so that is all in time. So no, to answer my question, we would love to have it, but no, there's no. And in our current biennium budget, also, there is still no admin costs. Again, the amount of money that we received actually didn't cover the full amount of prescriber hours that we had asked for or would like, and so we had to reduce that. So that's actually somewhat of an impact, but I think that we'll be able to, because of the overlap of the grants, we started diving into this biennium's budget this quarter. And so we should be able to make that up and do a budget adjustment down the line in order to support those prescriber hours that we weren't originally able to budget for. Because when we budget, they don't allow us to take into account how much money we have left. We just got to put 24 months in the budget and go from there. And so in this particular grant will end August 31st, is that correct, Stephen? August 31st. This new current biennium is the last day, and they won't allow any extensions past that. So we'll have to have all funds spent by then. So that's where we're at with that. Any questions on that? That was a great question. Thank you. So, but the current piece that we have right now, progress report, they actually did something different, which is what I'm working on right now. And it isn't necessarily for us to tell them what we're doing. It's for us to tell them what our overall goals and objectives are, because they're wanting to drill down on key items. When before it was you could just report what you're doing. Now they want to know what your goals are and your objectives, and you have to report to those. So I'm in the process of kind of putting that stuff together. Not as far as I would like to be, but I did, the one piece I did provide was our overall justice reinvestment objective, I guess, the right word, effort that we're doing. And so I did provide that to see if you guys had any feedback on that. Ultimately, our justice reinvestment recidivism rates for arrests and convictions are showing an increase. I will provide a caveat to that, is that our cohort, so the number of people that they're reviewing for the recidivism, is less than what it normally is. Normally we're at 30 to 35 people. This is like 22. So being a smaller county, when we have any type of small number like that, recidivism rate shows that it spikes obviously higher than that of a larger county for that number. But ultimately our recidivism rate for the arrests are increasing, and then our prison usage is actually, in my opinion, remaining the same. And so the CJC as well as the legislature are wanting to try and figure out, and I was talking with Mark about this before we got started, is what else are we going to do with the money that they provide to us through justice reinvestment? And originally it was provided so that we didn't open a prison at Junction City. And that was one of the main purposes, was to try and put money in the community and try and reduce the number of people going to prison. Well, I think the state has done that. COVID helped greatly with that also, because they did also release quite a few people and close another prisoner too. But now they're wanting it's always, what else are you going to do? And it's like, what we're already doing isn't quite good enough, but they want to know what else. So I'm trying to put some financial pieces to it, and a lot of other counties are doing that as well. For those that have received a downward departure, obviously the state saves money in prison beds. And so I'm trying to calculate what that is. And then additionally, our short-term trans leave, in order to receive justice reinvestment, we are required to take individuals on a short-term trans leave or STTL. And so I'm trying to put a dollar amount to that as well, but surprisingly, the data is not, just surprisingly unavailable. So I'm working on that. So my goal is to try and put those pieces of continuing to save money at basically what we're already doing. But overall, our overall objective is we want to send the right people to prison. We're not compromising on that. If they need to go to prison, they need to go to prison. And if they're in the community, we want to provide them with services and resources in order to hopefully not get them to that next level where they go to prison. And so we're not wavering on that piece in any way, shape, or form. So I just wanted to be clear about that. But other than that, that's kind of where we're at with justice reinvestment.
Jody, I have a question. Your reference to 30 to 35 people versus 22 people in recidivism. I didn't understand what you were measuring.
So the recidivism cohort, so for a 3-year recidivism rate, they look at the number of people who were discharged from supervision 3 years ago. So that body of people is at 22 right now. Previously, months prior, they're usually about 35. They're usually in the 30s. And so for it to be in the 20s, to me, just seemed a little unusual. And I feel like 3 years ago, that's towards the end of the COVID era. Who knows what impact that could have been? It could have been just a month that we just didn't have a lot of people discharging from supervision. So, but that's what that cohort measure.
So that would be 22 people for the month, for the year.
For the month.
Okay.
Yeah.
So, and they're measuring that on a month by month basis.
That's what, yeah. So if you go to the Criminal Justice Commission dashboards and the recidivism, the 3-year, you can actually click on it, just hover over it and it'll go by month. And so this last one that we're looking at the very end, it shows us at a spike, even though it's 22 people, but 16, I think it said 16 going off of memory, had recidivated. Normally we're in the 15-16 mark, but our cohort is in the 30s. And so it does show a little differently.
Okay, I think I understand.
With that.
Sorry, I'm not a statistician, so I have to look for that.
With that few people, do you have an idea what the main driver was?
I don't. I haven't had time to really kind of dive into what was happening 3 years ago, as far as, did we have a lower number of people who were getting off supervision? Were they kept long? I mean, I just don't.
Are you able to come back and see, okay, that's activities, that's where.
No.
Oh.
For that, I would have to request information, and I haven't, so.
The other question I have.
There's not a lot of good information.
The other question I have is on program. And maybe it's that I don't understand the program, but I understand it's Services in the jail for prescriptions and QMHP. And then crisis or case manager.
Case manager.
Okay,
So if you a halftime case manager to QMHA.
okay, so. Do we, and is that the entirety of what we're spending in? Just reinvestment on?
It doesn't cover medication costs. It
Yeah,
covers
but I
hours.
mean, there's no other component, there's no other thing we're doing.
No, there's just those three things. So you have the full-time QMHP in the jail, a half-time QMHA in the community as a case manager. And then you have prescriber hours,
Okay, so then.
whatever that costs.
The reason I'm asking that question is because when I looked at the answer to this question, the proposed answer, it doesn't seem to meet the question. In other words, how are those things? Having a case manager, which I'm not criticizing, that's wonderful. I love having, and having it in the jail is fantastic. I'm not suggesting a change. I just didn't see how this answer ties into that. In other words, how do those things work together to reduce recidivism? I'm assuming it does. I don't have any problem with that as a concept, but I don't think this answers that question.
So this answer is a general overview of what we want our justice reinvestment program to focus on. And overall, and this is developed from guidance that CJC has had. So I think that in answer to your question, there are other questions that drill down to your question. How does the jail mental health person provide a reduction in prison use or reduce recidivism? I haven't got to those questions yet. So this is just an overview of our justice reinvestment program. This is our overall goals, which is what they want, is a reduction in recidivism, a reduction in prison use. And what we're focusing our efforts on, and that is engaging individuals with treatment and mental health instability factors. And so that comes into play with both the jail mental health person as well as the case manager person. So we're providing them services and resources in hopes that they won't continue to commit crimes and hence go to prison. So this is just a 10,000 foot view.
One question out of.
One question out of many that I haven't even got to yet. So, the secondary, what do we want the QMHP in the jail to do? What is our objective of that? It's provide them services and resources, engage them with the community case manager in hopes that they have stability factors when they're released from the jail. They have medication, which is where the prescriber comes in. And that we're hoping that then they can have a warm handoff to the case manager. They're somewhat stable in the community and they don't continue to commit crimes or have drug use. So that is the secondary question. I haven't got to those questions yet, but that's a separate piece as far as our goals and objectives that I have to answer. And I don't have that for you yet. That will be coming. I hope that answers your questions.
With the interest in time, which this typically does not happen for this kind of meeting. If there's anybody that needs or wants to share information, just throw it out there. Anybody have anything to share for the rest of the group?
We can briefly share, we finished our 2025 stats for the year for the court. We are again, and this is in particular with criminal closing cases faster than we hope. So we don't have a backlog. We haven't for a while. Really the break that we have on how quickly things can be adjudicated in the criminal realm is basically capacity of the DA's office and capacity for his defense attorneys. Like I said, we can try a case as fast as anybody wants. The other issue with the court, to give you an update, we have our family, it is now known as Family Recovery Court. It's what we were calling Clear Court, but it's this is specifically addresses parents with dependency issues. We are quickly working ourselves out of a job. It's they're going to backfill us, but it's been really nice to watch kids go home with stable parents, and we've got a nice run. Our next step is an alumni program That people have stuck around and are part of it. Heard last week from the Department of Justice that they were amazed at how few staffings they are having now for termination of parental rights in Polk County. We just not have them. It's because the system is working, I think it's supposed to. So that's, from our perspective, it's good news.
Allison. I think you're muted, Allison. Yeah, you're still muted.
Thanks. Sorry. Yeah, just a quick announcement. Liberty House is changing up some things. Well, first of all, what I always say is, especially for law enforcement partners in the room, always let us know how we're doing. We've been a little short-staffed recently, but trying to keep our productivity up. So if you have any issues, good, bad, or otherwise, please always feel free to reach out. Along those lines, we've gotten a lot of feedback over the last year from board members and even community members. Like, first of all, nobody knows about us, which is weird because we've tried to address that over the years. And second of all, it's been harder and harder to do the fundraising. Just chasing the fundraising has always been a challenge just because it's a hard mission to talk about. And we found that the dinner dances at the very expensive Salem Convention Center just don't work. So we were doing something kind of gutsy this year. We scrapped the spring auction and instead are wanting to host a series of community meetings. We did one in Salem last week, and we'd love to do a couple in Polk County. So please know I'll be reaching out, certainly Board of Commissioners, Sheriff, and also our police chiefs to find out. Currently, we'd love to do one on Tuesday, March 31st in Dallas, if that's a time that would work. And then we're looking at the month of May for Independence, and we can certainly talk about Monmouth. And really the objective of the meeting is this is who we are, and here is a bunch of resources that we have, especially our prevention education trainings. And then, just letting people know how they can get involved as far as making quilts or whatever. And then we certainly will talk about it's not going to be a hardcore, very informal. The first one we did last week was about 25 people, and people just loved it. They had a chance to ask questions, and and it was really it was very personable. So that's what we're trying, and I would like to know, your permission. Certainly I can give the information to Sam if you'd like to. We have kind of a master list, and then if you would like, we haven't identified a location yet for the one in March, but of course, as I'm looking at your room, it's like, that's a really nice room. But anyway, so if that sounds interesting, I would love that feedback. And if you'd like to be a part of it, I would love that feedback as well. Thank you.
Sure. And Brent, I kind of want to add on to what Judge Hill talked about, those statistics and capacity in terms of the one statistic that I looked at for us in a large place was that number of referrals. And I mean, referral is any case that is sent to us from any, whether it's a juvenile case, whether it's a criminal case of any type that is into our office. Doesn't mean disposed of, doesn't mean anything like that. It just means just en masse coming into us, referred to us from the field. We are looking at just projecting on for fiscal year through this year. They are significantly higher than last fiscal year across all agencies, and just projecting that. It's not even, I can't quantify like double or a third or anything like that, but when I look at them, I would say when I project for any of our local agencies, that means all of our policing agencies, OSP, say everyone, when I see the projected result, it's not like within 10 or 15, which we quote margin of error, like, okay, that's equivalent. My eyes are like, wow, that is 30, 50 more for some agencies. So that's interesting. I don't have any assessment. I would ask chiefs or sheriff as to why that could be. There are a lot of reasons. So in terms of capacity, Judge, that will reflect on, I think what you're saying is, how does that turn around in terms of defense bar and I mean, some of these we hold. I mean, an example would be a DUI where we don't file it and we send it to the lab for testing, and so they don't get filed immediately. Our declines, we rarely seem to be declining anything, just sending it back for additional investigation. In terms of, you know, generic declines like that, but we are filing most things that we're receiving for different reasons, so it'll be interesting to see how that plays out in terms of capacity. We have one open position for a prosecutor right now, and, you know, I don't know when we're going to fill that. We're being selective in terms of the applicants we're getting, so that may be open for a while. And our capacity to do all the things, you know, we do the RAD docket, so that takes one prosecutor. 1 day of the week for that caseload, et cetera, et cetera. Everyone's busy for different reasons. So it'll be interesting to see how our capacity is impacted by that as well. So just point that out.
Officer Roll, I'd just like to tell you thank you for the increase in your officers on 99 and 22. I see them constantly, so we really appreciate you stepping up and providing that for us. Thank you.
Anybody else have anything else? May 4th, next meeting. May 4th.